Welcome to the podcast of Hemisphere, the official journal of the European Hematology Association. Hemisphere's podcast presents insightful, expert discussions about recent hematology publications. We hope you enjoy.
Hello and welcome to the Hemisphere podcast. My name is Charles de Bock and I'm your host for this podcast today. And I am joined by Professor Josef Vormoor, who is the clinical director at the Prinses Maxima Centre in Utrecht University Medical Centre in the Netherlands, and also by Associate Professor Maria Ester Bernardo at the Università Vita Salute San Raffaele Medical School in Milan, Italy. And today's topic is we're going to talk about the best of pediatric hematology at EHA 2024, which was held in Madrid, Spain. So welcome to you both.
Welcome. Hello, Charlie.
Welcome and nice to see you both.
Likewise. It was a fantastic meeting. I really enjoyed it. It was a long way to travel from Australia, but it was well worth it. And pediatric ALL is my specialty in particular, so I was quite excited to see many of the talks. I must put the caveat that I'm a fundamental researcher and not a clinician. And I'd like to begin talking about the very thought-provoking lecture given by Professor A.J. Vora from the Grand Ormond Street Hospital. And he talked about de-intensification of treatment for pediatric ALL. And the reason why I thought that was quite thought-provoking, because he really mentioned that, are we over-treating most of our children today? And that's the first part that he kind of raised. And then, do we see a chemotherapy-free future? So maybe, Joseph, I can perhaps start with you about your thoughts on AJ's talk.
Yeah, if you go back into the 70s or 80s, we cured about 60-70% of children with ALL, with much less intensive therapy than we use these days. But the problem is, well, we have made huge progress on really identifying patients who have a super high chance of cure and patients who need a bit more intensive treatment. But pediatricians, we are very conservative. And so we are at the moment trying to very carefully reduce treatment in those patients who have a chance of event-free survival of over 95%. But we don't want to do it too fast because you don't want to increase that the leukemia comes back. And so perhaps we are not bold enough. I think maybe the answer. And immunotherapy offers a fantastic new chance for us to make really big steps. And it is interesting in a way, as pediatricians, we always thought we have to teach our adult colleagues how to treat ALL because it's more common in children, and we were really the pioneers in successful therapy for childhood ALL. But if you look at the moment, the most creative and therapy concepts come from geriatric hematologists, because if you're my age, if you're over 60, you just don't tolerate any chemotherapy or not the chemotherapy you have to give for an ALL treatment. And so they come up with these chemo-free treatment protocols, which are basically based on immunotherapy. And that is revolutionizing the way how we treat ALL.
Yes. I mean, so to come into the immunotherapy, clearly blinatumomab is making massive headroads into the way that we treat children. I mean, at the moment, as far as I understand, it's more at the relapse refractory setting. But as AJ pointed out, should it be put up front? And I think he mentioned, that blina should be used with low dose chemo, because that is the same outcomes if you use blina plus low dose chemo and then full intensity chemotherapy have exactly the same, and there's obviously less toxicity. And from a personal perspective, I have a friend who I went to university with, and his daughter just had a relapse BLL, small world, and then she's on blina. And I can tell you, for the parents, when the child is on blinatumomab, it's like a wonderful situation in terms of the toxicities, because there's very little. So where do you see, I guess, the future for blinatumomab in children? Up front, and is that the key?
Absolutely. I mean, we in infant ALL, which until recently had a very, very high relapse rate. Um, um, there was a study run here from the Maxima by Rob Peters and Inge van der Sluis, where they introduced Blina into the treatment frontline of infant leukemia. And I still remember I had long discussions. I included a patient of mine in this study, and we had hours of discussion whether it is safe for a baby to give such a new drug. And eventually, parents were convinced that this is the right step and had thought about very well. And then later on, mom tells me, wow, the 8 weeks I was on Blina was the only time I had a normal and fit baby at home. And if you look at the recent New England Journal paper, the introduction of Blina improved 1-year event-free survival from 60 to in the range of 85%. So it was a massive improvement of therapy. But it not only improves outcome, it reduces toxicity. And AJ Vora and his team at Great Ormond Street in London, they have had a very interesting publication in JCO where they published their real life experiences, where they used Blina in patients who had intolerable toxicity. And the patient who received Blina did at least as good as the comparator group, which got intensive chemotherapy. So I think, yes, we need to introduce Blina and other antibodies like inotuzumab into frontline therapy. And in the ALL Together Consortium, we also do this in the study context now for children with Down syndrome ALL, because again, children with Down syndrome don't tolerate the chemotherapy as well and have way more side effects. And again, we are trying to keep up the good results, but with lesser toxicity.
Yeah. I mean, I guess because that was the thought-provoking part from AJ, where he said, are we becoming complacent, where we think that, that 85% is okay? And maybe my question to both Maria and Josef is, do you think that we can get to 100% with immune therapies? Is that too lofty a goal? And if I can be so bold, and we wanted to go to a chemotherapy-free, if it's possible, and 100% survival, what will it take, I guess, to get a change to what, what are we looking at? What are the hurdles that we need to overcome?
We need bold pediatricians and bold parents. But I think indeed this, because we only can do it together with the families, and it's a combined decision. But if we don't dare to aim for 100% cure, and if we don't dare to aim for a chemo-free therapy, then we'll never get there. We need to do it in a cautious way, in a well thought through way. But I completely agree, we are in a phase where we need to be bold again, because there's lots of gain for our parents. Yes, we cure a lot of patients, but it's a 2-year treatment with a lot of impact on quality of life. Vincristine, dexamethasone, the effects on the families and sisters, brothers, everyone is huge. And I think that cannot be the answer. It's good that we have achieved this, but this cannot be the end.
That's true. Maria, your thoughts?
And if I can comment, Joseph, I guess you would agree that, you can intensify it has been a revolution in the treatment of leukemia in the past 20, 30 years. Research has gone fast. Researchers have been able to identify new drugs, innovative approaches, more targeted treatments, and I expect in the future to possibly see more, right? We are on a way that where we have developed technologies, for example, based on gene therapy also, that allows us to possibly implement novel treatment, novel targeted treatments. So based on what Joseph said, of course, we it's a dream to cure 100% of the kids, but it's difficult to predict. But what I would expect is that we can even improve. We can further improve from what we have today if we continue on developing innovative and more targeted and safer approach possible.
Yeah, I tend to agree. I think as a fundamental researcher, the aim is obviously not only just treating the cancer, but making sure that the toxicities are as low as possible. That's the key, right? Because having seen, and Josef, you mentioned that it's not just the cancer we're treating, it's the family unit as well. The sisters and brothers, that whole journey that they go through for a long period of time is quite heavy on the families. And I mean, we've done well for BL. Yes, Maria.
Sorry, no, I was also thinking about late effects of these children who are cured. So this is a good reason for reducing toxicity and considering possible safer drugs, because once they are cured, they have a life expectancy which is much longer than in the past, and there are a number of other issues that may occur later in their life. So that's why, again, interaction with pediatric and adult hematologists will help a lot in understanding better the course of these patients who become adults.
I mean, dare I ask, before we move on to the second topic, gene editing, I just want to finish off on the immune therapy part, because clearly we've made a lot of headway for BALL. The holy grail, of course, is TALL in a way, something close to my own heart. There's CD7 CAR Ts, I guess, coming through, but, what are your thoughts on, will we ever get maybe a non-T cell specific antigen, or are there, how's the technology looking, or the clinicians for having immune therapies against TLL? Any thoughts, Josef?
Yes, it's one of the big challenges. I think at the moment our immune therapy works best in the B cell compartment because we have lineage specific antigens and it's a replenishable organ. So if, at least in a child, if you ablate all B cells, they can reconstitute. And even if they wouldn't, you can actually live without B cells, because we know that there are immune deficiencies like Brutons where you don't have any B cells. And if you regularly substitute the patients with immunoglobulins, you can live with that. So I think there is some theoretical advantages that explain why immunotherapy is so much more successful than B cells. T cells is the problem, and in principle it's also a replenishable organ. You also have T cell specific antigens, but you can't live without T cells because we really very quickly get viral infections, fungal infections that are very difficult to treat if the patient has no T cell function. So that makes the application of T cell therapy a bit more difficult. There are ideas how this may work, and CD7 CAR T cells I think will be very interesting. I think in the beginning it may be a bridge to transplant, but I hope in the long-term run that we find T cell specific therapies which have a very short duration and that we can help people get through so that their own healthy T cells can reconstitute. And in principle, it's the same problem just for T cells. In myeloid leukemias, you have the same problem. Are people thinking about it? Are there antigens that are specific to the malignant clone that do not sit on normal hematopoietic stem cells? Because AML cells or AML stem cells are so closely related to normal hematopoietic stem cells, and again, without a hematopoietic system, you can't live. So is AML therapy in the future a bridge to transplant, or is it, will we be able to identify antigens or combination of antigens that are leukemia specific?
So I think this makes a nice segue from, in terms of how we think about new technologies, to CRISPR and gene editing, Maria, which is the session that you chaired at EHA. Because, just like with CAR T cells, there's lots of ways that we can think about changing the CAR T construct using genetic engineering, but at a more fundamental level, in terms of pathogenic forms of hemoglobin beta and correcting that to reactivate fetal hemoglobin using CRISPR. Very exciting times with Exocell coming and FDA approved. So give us your thoughts on the field and where it's going in terms of CRISPR and overcoming some of the challenges on that side for therapy.
Thanks for asking. I think you are right. Also in this field, we have testified really big changes and evolution. And we are in an era where we have already products available on the market based on gene therapy technologies, which are, as I said, available for patients. And there are new technologies, more and more precise, which are in a preclinical stage, but will hopefully in the near future become also available to patients. So as we said before, in a way, in the last 15, 20 years, we have been able to develop more innovative technologies to manipulate the DNA. We have started, and this was already 30 years ago, with gene addition. So with lentiviral-based hematopoietic stem cell gene therapy. And this was mainly done by, and it's still actually clinical reality, and patients are cured by lentiviral-based gene therapy with hemoglobinopathies and a few other diseases. So the idea there was to add into the patient genome through a lentiviral vector a gene, a therapeutic gene, which was altered in the underlying disease. So in that case, through the properties of the vectors, we were adding into the genome a new corrected gene, whereas since gene editing has been developed, we have been able instead of adding to precisely correct the genome, so to perform cut and paste and be really targeted and precise. And one of the presentations during the ESEH symposium, which was by Julia Orduin from Imaging Institute in Paris, was about base editing, which is a CRISPR-Cas9 based technology, which goes to precisely modify and change bases in the genomic DNA, which means that we are really touching a little piece of DNA. This is associated with less toxicity, for example, less double-strand break toxicity. So this brings us to a technology that will allow us to be very precise and to limit as much as possible the toxicity that we can induce into the patient genome. I think this has the potential, is having the potential to revolutionize the treatment of patients with hemoglobinopathies, not only thalassemia, but also sickle cell disease. Very relevant in view also of the fact that there are thousands of patients in non-rich countries in Asia and Africa who would be in need of being cured for such diseases. And this brings us, I think, also to some of the hurdles and bottlenecks in the development of such treatments. We know how efficacious they can be. They can cure transfusion dependency and make patients free of any chronic transfusion and related toxicity lifelong, but they're also very complex to prepare and also very expensive. So I think we have a duty as researchers and clinicians in make these products as most sustainable as possible. And this is, I think, an issue that will be discussed a lot in the scientific community in the future, how to make these products, which are life-changing, available to as many patients as possible.
I think you raised a few points there. I like the history, how it's changed from using lentiviral, and really that's quite, in terms of quite a toxic mark on the genome. And if memory serves, I think some of those children actually then develop leukemia because the insertional mutagenesis which occurred. And now we've got this other technique of CRISPR-Cas9, which then makes double-stranded breaks, apoptosis, all sorts of inflammatory repair mechanisms that are activated. But the base editing with a dead Cas9 fused to a deaminase, as you say, is the lighter touch. So again, we can see this evolution of the therapies as people realize that the intent was correct, the execution wasn't so great to begin with, but maybe that's going back to being bolder at the beginning, and now we're, fear of maybe leukemia as a result of trying to fix a gene, and then now we've got to the stage where we've got deaminase. I think is extremely exciting.
Yeah, if I can add a detail, you're absolutely right when referring to the first cases. Well, the first attempts of gene therapy already 40 years ago, when we had a few cases of leukemias and lymphomas, this was done not with lentiviral vectors, but with retroviral vectors.
Yes.
Which are the very first vectors employed. And indeed, already lentiviral vector changed a lot the landscape of insertional mutagenesis, since lentiviral vectors are much safer because they insert randomly within the genome. So there has been we don't want to go into details, but there has been very, very few reports of insertional mutagenesis when employing lentiviral vector. And indeed, today lentiviral vectors are employed in the clinical setting, and we have few products available on the European and US market which are based on lentiviral vectors. So already a big change in terms of safety, despite that remains an issue that needs to be monitored. And now with more recent technique that we really hope to see in the clinics soon, such as base editing, as you said, you really limit the toxicity on the DNA, like activation of P53 and DNA damage response. So this is really key to advance the field.
I think what's nice about the fact for this one for reactivation of fetal hemoglobin is the fact that you're actually removing a repressive mark by destroying the BCL11A enhancer region. How universal do you think that's going to be for other gene editing where we can remove a repressor? That's a lower bar with CRISPR and base editing, because you just have to disrupt something rather than correct something per se. So do you think we'll come to a stage where we can actually start to correct rather than remove repressors in a way?
I think possibly yes. At least we see this possible in preclinical setting. I think we still need time and a lot to study again, also in terms of safety of these techniques once we bring this to the clinics. But I think the idea for hemoglobinopathy was indeed very smart. So reactivating fetal hemoglobin and employing something which is naturally present in our body to correct a defect in the beta globin gene is actually a very, very smart idea and has worked very well. I think similar ideas are coming, of course, applied in different diseases, but also the possibility of really correcting, cutting and pasting, at least, as I said, in a preclinical stage. Again, since we are touching the genomic DNA of our patient and the genome, we have to be very safe. And before being able to bring new technologies to the clinical setting, we have to provide toxicology data, biodistribution data of all these new technologies before being able to propose this to patients. But indeed, I think we will see more to come in the future.
I think, will this be the, I think I read, replacing allogeneic stem cell transplantation? I guess that's the key, right? So no more.
Indeed, the idea is that, ex vivo gene therapy with hematopoietic stem cells is actually an autologous transplantation, which overall, as compared with allogeneic transplantation, which represents a standard of care for many of these genetic diseases, not only hemoglobinopathies, but also congenital immunodeficiencies or some metabolic disorders, autologous transplant is safer overall. Well, you completely avoid the risk of immunological complication in autologous transplant, so no graft versus host disease, the risk of reactivating viruses and having infections is reduced. So overall, autologous transplant is a safer approach as compared to allo. And in some of the gene therapy approaches, we're also able to use reduced dose of chemotherapy to prepare our patients, and this is again another possible advantage. And going back to chemo-free treatment, So there is a lot of interest also in the field of gene therapy in developing, for example, chemo-free preparative regimens which are given to patients before gene therapy. So there are antibodies against CD45 or c-KIT which are being developed with the idea of selectively depleting hematopoietic stem cells of the patient in order to make space for the new gene-modified cells. So if we are able to combine limited side effects as compared to allotransplant with possibly biological or chemo-free or reduced intensity conditioning regimen, indeed ex vivo gene therapy might be able to replace allotransplant in some of these specific indications, and one possibility is definitely hemoglobinopathies.
And I think it's a wider theme, I guess, in pediatric hematology, is how can we perhaps not replace but transform hematopoietic stem cell transplantation through cellular and gene therapies. If you look at CAR T cells, we didn't talk about CAR T cells earlier in the treatment of ALL. Again, they're revolutionizing the treatment of relapse ALL. And one of the key questions is that people are addressing is, can you actually replace stem cell transplantation, or at least 30-50% of stem cell transplantations through cellular CAR T cell therapy? If we could achieve that, again, that would be a major step. Not cure may be the same, but toxicity is much less and quality of life will be less, or much better.
Much better. Excellent points. Maybe I can now move to predisposition session, because, you know, when I think predisposition, I'm always only thinking of Lee Framini, but clearly there is a very wide field now of, I guess, an understanding that there are increasing genetic factors outside of just P53. Josef, your thoughts on where the field is going and some key highlights from EHA this year?
It's an interesting question. It comes back to one of the most frequent questions we get asked from the parents of our patients. That says, why does my child get leukemia? Is there a cause for it? And most often we say, no, it's bad luck, it's chance, it's we've learned a lot, particularly from the work from Mel Greaves, that typical childhood ALL may be an embryonal misdevelopment, and the first changes on the route towards leukemia happen in a fetal, perhaps liver progenitor cell. And we know, like with autoimmune disease, that delayed exposure to infections may increase the risk. So there's clearly something with lifestyle which has an effect. But in generally, I think will always be a certain incidence of children who get leukemia. And then is the question, is this just chance, or is there a genetic component? And we are realizing more and more that there is a fraction of children where we actually find predisposing mutations, and that often is genes that also play a role in cancer predisposition in adults or in cancer development in adults, but they just occur in a different, in a germline context, and then help on this process. And so I think at the moment we don't really know how high is the incidence of children who really have a predisposition. I guess it also depends on how your definition of a predisposition. There are weaker genes that have a lower risk of cancer, and there are higher risks, as you mentioned P53 and Li-Fraumeni. But I think it will be important for us to really get a comprehensive understanding of this, because it will have an impact on how do we follow the children up. Do we need to think about the family? Is there other children who may be affected? Do these genes that affect to cancer have implications on how you tolerate your chemotherapy? Do you have a higher risk of developing secondary cancers? So do we have to adapt our therapy? So I think these are questions where we at the moment just stand at the beginning, but it's clearly much more complicated than I ever thought 10 or 20 years ago, where they said ALL, there is no predisposition except in some rare cases. I think the reality is more complex, and we need to learn a lot from this. And I think the session that Jan Lufen chaired there gave a good overview of what we know at the moment and what are the key research questions we have to ask.
I think you're right in terms of, I guess there's more discussions about the fact that predisposition is not just an outsider or crazy idea, that there is a definite genetic element. And I guess with whole genome sequencing coming through, these variants of unknown significance start to become, as the population who was sequenced in germlines that are sequenced more, and that number becomes larger, we can start to then look for stronger patterns for those variants of unknown significance and understand that level of, well, it's not heritability, but whether those individuals are more at risk, and then the implications for obviously genetic counseling for families to give them informed decision makers. There's always, I guess, risk, right? That's the key. And I think it's really nice that these sessions like at EHA are starting to ask those questions with a dedicated session, which is, I think, maybe 10 years ago, you might have been the only person who would have been talking about genetic predisposition and leukemia.
And we learn, I think, more about the origins of leukemia and cancer as well. Are these predispositions caused by you have a higher mutational rate? Are they caused by an immune deficiency and lesser immune surveillance? We know that inflammation in this delayed response, the delayed exposure to infection plays a role in development of childhood leukemia or loss of the pre-malignant clones, and which role does inflammation play here? So I think we also, by understanding what predisposes or gives you a higher risk, we're also learning something about the origin of the disease. Whether this will eventually lead to early diagnosis of prevention, I think is much too early to say.
And I guess we need excellent models as well. How do we test these hypotheses with predisposition? And that's probably a major challenge for the field. There are a few mouse models out there which are contentious, but at the same time are informative. And I think it's getting it's a robust field, which was really nice. I like seeing those sessions.
But it's really, I think the number games is a challenge, because fortunately childhood leukemia is a rare disease. So to really identify predisposing factors, you need an incredible amount of patients and control groups to really be sure that there is a causal relationship.
But we're getting there. That's I think now with the cost of sequencing, and there's more collaboration and sharing public data, I think those data sets are becoming larger and larger. I mean, we've just seen on the preprints, from David Tichy and Charles Mulligan, 1,300 patients with TLL who have undergone whole genome sequencing. And who would have thought they could now relate that to clinical outcomes? And I think, that's a bit of a game changer as well, which has just come out. And then I saw another paper came out, I think today, in Blood on the role of CMV. And you mentioned infections with leukemia and how inflammation can be either pro or anti-leukemic in different contexts. And again, lots of questions being raised about the role of that in predispositions.
Yeah, absolutely. And it also highlights that we really need to approach this as a global pediatric oncology community. We really need to work together, because in all our little silos countries, we just don't have the numbers to address these questions.
Absolutely. And of course, the best place would be to come to EHA, of course, to meet like-minded individuals.
Yeah.
So other areas, Josef, that you wanted to cover, or Maria, you wanted to cover, is the best of pediatric EHA 2024 that I haven't mentioned.
There's just two things. I mean, we always want to encourage pediatricians to come to EHA, And we within EHA, we're actually learning to label the program even better, that you'd find the things you're looking for. But there was a fantastic session organized by Jan Kohls over ALL, where a lot of pediatric experts, key international experts like Sarah Tation spoke. And it wasn't even labeled as pediatric hematology, but it was the kind of the core and best what pediatric hematology has to offer. And what I also really like is that we are reaching out to other societies. So the session we just talked about with on thalassemias and genetic correction was a collaboration between ISCH, and I'm flying tomorrow to ISCH in Chicago, where we have a similar EHA ISCH session on sickle cell anemia. So I think because we reach out also to other communities, I think we bring the best to EHA. It is really an incredible forum for exchange of knowledge and collaboration.
Maria,
And
your
Joseph,
thoughts?
if I may add, because we mentioned this many times, so on one side, I think we can tell to pediatricians that at EHA congresses, they will definitely find their spot, because there are many topics either dedicated specifically to pediatrics or distributed around in sessions, but also is the chance for collaborating and creating connections with adult hematology, right? We always try to make this connection because we believe that EHA is such an important forum for exchanging expertise and abilities to study further. So there, I think it's the place to be if you really want to engage with adult hematologists and exchange knowledge and expertise and create active collaboration, which is not easy, of course, if you go to congresses which are only dedicated to pediatrics or adults, but there is the place.
I couldn't agree more, particularly also if you think about the young people, the AYA agenda. We need adults and pediatricians working together. There's so much we can learn from each other. But you not just have adult hematologists there, you have also the basic science community. And I think it's this interdisciplinary exchange that makes it such a fantastic meeting.
I agree. I think, in the end, I always like to tell my team, science is a human business, right? It's about working with people with common ideas and common goals. And where do you meet people who are like-minded? It's at congresses and conferences. And you have to be ready because, you might ask someone a question about a topic, and then what's great about EHA, the amount of times where I've asked someone and they'll say, well, I don't know, but who you should see is you should go and talk to that person over there at that poster, because they will be able to answer your question. I think that's what makes EHA quite unique. So maybe I can finish on next year, Milan 2025. Expectations. What do you hope to perhaps see or hear about in the future in a couple of sentences? Maria, I'll start with you. What would you like to see at EHA 2025 in terms of
course,
CRISPR?
first of all, of course, I'm very happy because EHA will be in Milano, which is my city. I actually live in Milano. I'm not from, I'm from the north of Italy, not from Milano specifically, but I live here and work here. So it's a great pleasure to have EHA here and to connect with people here in Milano, and have the chance to have also them coming over to our center. Starting from gene therapies, I'm sure we will see more, not only in the field of hemoglobinopathies that we mentioned many times, which is very relevant, especially because of the numbers of patients that are present worldwide, but also for other diseases. I mentioned congenital immunodeficiencies, some inflammatory diseases, metabolic diseases, but especially for children in the field of pediatrics. There is a lot really to come and to see, and the possibility to cure children with rare genetic defects who have a high unmet medical need and do not display available efficacious treatment options. So I expect to see more and more, hopefully, sessions even dedicated to gene therapy and its developments. I think, again, we will see, and then I will leave it to Josef. I think treatment of leukemia in kids and especially ALL, we will talk a lot more. And this bridging, again, with adult hematologists learning from each other on how to be less toxic and possibly identifying scheme of treatment which are, if not chemo-free, chemo-reduced. I think there will be a lot of research again, more and more to come on cancer predisposition. I think we probably know only a little bit of what is there. So as you said, by studying, making whole genome sequencing studies and putting together enough data, we will be able to know much more. And I think in these fields, a lot is going on. And then maybe, Joseph, you want to add more?
Yeah, my dream and hope would be that we indeed see more about immunotherapies for TALL and acute myeloid leukemia, because there really is one of the big challenges we have at the moment in our field. And as the co-chair of the EHA task force that together with Anna Castleton, I think we have done a fantastic, it's not published yet, we have done a fantastic, how do you say this, questionnaire run across the ER community with incredible amount of responses. So it really allows us from a physician's perspective how to map EHA services, and you see the differences, and I hope we can bring these differences and the needs, how we support this group of patients, that we can bring this to the table.
That we actually didn't touch that, but I did remember seeing Helen Orum's talk about the transition of AOAs, but we'll have to save that for another time. We are at the end of our time. I would like to thank you, Josef, and you, Maria Ester, for a fantastic discussion over the last, I think, 40 minutes on the best of pediatric hematology at EHA 2024. And I look very much forward to Milano in 2025, where I am sure a lot more amazing research in this field is going to be presented, and greater insights into all of the topics that we discussed today. So thank you so much.
Yeah, thank you, Charlie. Thank you, Maria Ester.
Thank you both, and see you in Milano.
See you in Milano.
Absolutely.
Thank you for listening to this episode of the Hemisphere podcast. All of Hemisphere's content is open access and can be found at www.hemispherejournal.com. We hope you will join us for future podcast episodes.